rhetoric has been around for a long time. So I wonder what you see as the difference in the new arrangement that's going to give you the...
Are you deciding for that, whether you're coming down or not?
Okay, so you're going to be here all day, so there's a couple later this morning, which we assume you will be.
Okay, so if we could carry on, please. And again, apologies for the change in the programme. I'm sure Stephen is equally apologetic about not being here. And fortunately, we had in the building, if you haven't seen the exhibition, we have some exhibitors, and please do go and say hello to them through the course of the day. Fate has decreed today that another Glaxoid colleague of mine, Mr. Kevin, what was your surname again? Blakemore, who is now heading up the absolutely fabulous partnership team at the ABPI, was around. So I don't know whether you're going to do the whole of Stephen's speech or you're going to do a promo for the or whatever. So whatever, welcome to the podium. Thank you.
Thank you, Alan. So, good morning, everybody. It's an unexpected pleasure to be here today speaking to you. And one of the things I can say is that the only constant in life is change. And as it says here, whilst it's disruptive, inconvenient, and sometimes uncomfortable, and trust me, all of those things are true in my situation, we must not forget the opportunity that the energy this creates in helping focus our minds on key questions. And a key question that we have is, what healthcare system do we want in the UK? And what strategy does the industry need to pursue in order to continue to deliver innovative new medicines? Medicines which make a huge impact on the life of patients and their carers, and medicines that, when used appropriately, actually save system costs in a sustained and cumulative way. So, as the NHS, our customer, changes, so must we. First, let me introduce myself. I'm Kevin Blakemore, and I'm the National NHS Partnership Manager for the ABPI. I'm standing in for Stephen, who is unfortunately unwell today. The ABPI represents research-based companies, large, medium and small, leading an exciting new era of bioscience in the UK. We are recognised by government as the industry body for consultation on the pricing and use of branded medicines in the UK. This includes the recently started negotiations for a new voluntary agreement, which will no doubt prove challenging. Before I move on to the main subject of the session, I think it's worth restating the contribution of this industry to the NHS, to patients and the UK. Collectively, our industry supplies 90% of all branded medicines used by the NHS. No other sector has been so consistently productive, and no other part of the NHS expenditure comes under such scrutiny. This is despite the fact that the percentage of NHS spend that goes on medicines has fallen to 9%. I also believe that we should feel intensely proud of the fact that the pharmaceutical industry has enabled the healthcare system to survive by providing good, valued medicines, and has enabled the treatment of several diseases to be managed incredibly cheaply. Things like serious mental health conditions, heart disease, several cancers, diabetes, and HIV, to name but a few. So, thinking about the new NHS, what impact might this have for the pharmaceutical industry? Following the passing of the Health and Social Care Bill, we are seeing different structures and stakeholders emerge. The National Commissioning Board and clinical commissioning groups are starting to take shape. We can already feel a cultural change from the Department of Health and the National Commissioning Board. We're going to need to form new relationships with all parts of the system, from clinical senates to academic health science networks to the health and wellbeing boards and others. The change is enormous. At the heart of the Act is the intention to move power and accountability from the centre out to the local areas. And you've already heard this morning exactly how that is being planned and done in Crawley. This presents a potentially more disparate landscape for us as an industry to interact with. A trend we can expect to continue and indeed become more pronounced within the new NHS is variation. The variation will impact on how we as an industry operate locally. We know that one of the ways of increasing efficiency is to remove variation. However, the recently published National Metrics report shows that NICE-approved medicines are being underused by the NHS in half of the disease groups that were reported on. The report, which is published by the Health and Social Care Information Centre, illustrates where medicines use is lower than, in line with, or higher than NICE expectation. NICE-approved medicines are shown to be cost-effective. The NHS is required to fund them, and the NHS Constitution gives patients the legal right to NICE-recommended medicines if their clinicians believe them to be appropriate treatment. Now, it's worth noting that the picture for some of the medicines showing underuse in 2010 has actually worsened during 2011. The report also shows that doctors are prescribing older generic medicines at a higher level than NICE expectations. This is the result of a very long time it takes for some medicines to reach or exceed NICE estimated levels, by which time they've lost their patent and can be prescribed cheaply by the NHS. It's in everyone's interest to keep the medicine's life cycle in balance, and so it's important that the savings that the healthcare system makes on generics are then reinvested back into the new innovative medicines that this industry produces. We know that the UK constantly lags behind our international colleagues on the uptake and access of new medicines. It's also clear that there's too much unwarranted regional variation, so in some parts of the country people can access a medicine, whereas just a few miles away another person can't. We need to play our part in addressing these problems as a matter of urgency. The challenge for the new NHS is how to balance the twin objectives of eliminating the postcode lotteries whilst maintaining that local freedom. We should not forget that this new NHS also has to be ready to meet the challenges of the future. Demand is growing at 4% a year. We have an ageing population with increasing chronic disease and rising public and patient expectations coupled with all the new technologies. The £20 billion of savings required under the QUIP challenge means that the service needs to achieve unprecedented efficiency savings. This too will require partnership across all those involved, from service delivery to early discovery. It's worth spending a few moments thinking about what partnership really means in this context. One of the things I believe is that being a partner means having shared risk and shared gain. For any partnership to be successful, it has to be able to adapt and respond flexibly to a rapidly changing environment. Partners must trust each other. And let's be honest with ourselves. As an industry, our behaviour in the past has not always engendered trust. That is in the past, but it takes time to change culture and perceptions on both sides. We need to re-establish our social contract. We all want to see greater transparency. The pharmaceutical industry is truly global and consists of hundreds of companies, so change on this scale does take time. We recognise that our relationship with clinicians must be beyond reproach. The AVPI Code of Practice has strict sanctions for those who act inappropriately, and this is enforced rigorously by the PMCPA. But we're going further still. The AVPI has been involved with the Ethical Standards in Health and Life Sciences Group to work with all health professionals across the NHS. The group is now in the process of consulting on issues from medical education to the public disclosure of payments to healthcare professionals. Making sure we get this right is essential to building healthy partnerships. The Innovation Health and Wealth Programme is a good example of a cultural shift towards working in partnership. This is a unique opportunity to partner with the NHS and at a national level through the IHW team to drive an agenda where we both have a common goal. We are now nearly a year on from when IHW was first announced. We have 19 people from member companies who work on 12 task and finish groups alongside colleagues from the NHS, from regulators and from professional bodies. I'm really pleased with the progress that we've made to date, but there are areas where we still need to make an impact, and it's essential we redouble our efforts to drive IHW forward. One element of the IHW programme, which will require genuine partnership, is to deliver effectively the new academic health science networks. These offer a great opportunity as innovation adoption vehicles, but we as an industry need to invest time into them. We already have some great examples of partnerships with universities, charities, and the leading teaching hospitals. But we have to win hearts and minds and not just rely on one partnership being mandated through national directives. At the ABPI, we have invested significantly this year in building a dedicated NHS partnership team. The purpose of the team is to build strong, sustainable relationships between industry and key regional NHS figures, and ultimately to address a range of healthcare challenges and spur more rapid access and uptake of innovative medicines. We are a team of 5 experienced industry professionals, one for each of the 4 regional commissioning offices, and with me as the team manager. One of the newest members of the team is here today with me. Her name is Karen Thomas, and she's joined us from Bristol-Myers Squibb, and she is responsible for the London region. We'll both be on the ABPI stand later, so please come and talk to us about partnership and joint working. Other members of the team are Diana Vey and Harriet Lewis. Now, Diana is responsible for the South region, and she joins us from a career which has spanned working for AstraZeneca and UCB, Abbott Laboratories, the NHS, and Humana Europe. Harriet, who is a qualified pharmacist, is responsible for the North region, and she joins us from NICE and the National Prescribing Centre. I'm still in the process of getting the Midlands Regional Partnership Manager in place, but I'm hoping that next week I'll be able to announce who that individual is. Now, the team work to improve uptake and health outcomes in each region, but generally do not promote individual companies or products. One of the new structures that we have to facilitate this are regional industry groups. Now, these groups have 3 main objectives. They're to provide input and shape regional business plans with the regional partnership managers, and to develop the stakeholder plans, to identify barriers to uptake of innovative medicines, and to agree solutions and action plans to remove them, and also to review opportunities for partnership working identified by the regional partnership managers and agree how those opportunities should be progressed. I'm hoping that these groups will help unlock some of the areas in which we can make a real difference, specifically through redesigning the pathways of care, where we know this is where improved patient experience and real financial efficiencies can come together. I'd like to share with you an example of where this has worked in practice. It's a joint working project that was carried out between Aintree in Liverpool, Aintree Foundation Trust, and Baxter Healthcare. The Accident and Emergency Department at that hospital wanted to improve the management of patients suffering from epistaxis, that's nosebleeds. The aims of the projects were to firstly educate and train A&E staff to better assess patients when they arrived in the department, to develop a new patient treatment pathway for management of nosebleeding, and to reduce hospital admissions and length of stay for patients suffering from the condition. The results have been really impressive. Very simple idea, but a reduction in hospital admissions of around 27%, a reduction in hospital bed days of around 22%, and that actually generated a saving for the hospital of over £100,000 over a 12-month period. And that was because of the introduction of a product that Baxter make in the management of epistaxis in the A&E department. And that was just through treating 25 patients with that particular product, made that saving by keeping patients out of hospital. If we adopted that across every hospital trust in the country, think of the savings. It soon starts to add up, and that's just one idea. And there are hundreds and hundreds and hundreds of them out there like that. We need to share it more. So our challenge is to adopt and implement those good ideas across the NHS and work together to make it happen. One of the questions that's often been asked and to focus on is, why is it so difficult to implement internal industry change focused around new customers? Well, I think there's several reasons for it. First of it is company culture. Understandably, there is a reluctance amongst businesses to let go of a model which has been successful for over 40 years. In the past, changes involved expanding, contracting, changing the roles, often of field forces. But the new NHS needs us to change not just our numbers, but our thinking and our attitude to risk. The NHS needs to do the same too. Historically, we've been excellent at delivering 3 key messages. And in the future, we're going to have to be much more able to have a much wider ranging discussion